review articles this 3 years,
Sir.
they'll nearly 15-20 cardiology will be covered.
Okay, sir.
Most of the recent things are recent concepts about management, all those things will be covered. So minimum you will get some 3-4 questions from these topics. See, last time we did, that's why peripart and cardiomyopathy, hepatic, all of them were all studied and we did seminars, na?
Yes, sir.
So they're all clinically oriented. One or two will be there, very basic sciences like molecular biology or genetics. Sometimes that you also, for an advances, they may ask like that.
Okay, sir.
So you may not remember the articles, review articles, and sometimes they have this case seminar scenario also, and editorials depending upon the study. They will give more information and it will be useful for us.
Okay, sir.
Okay.
Initially, in the initial part for the introduction, I'll be dealing with the anatomy of the mitral valve and what is mitral apparatus and what is subvalvular apparatus. Mitral valve apparatus consists of mitral valve annulus, mitral leaflets with commissures, chorda tendineae, papillary muscles, and the supporting left ventricular valve.
Previously, we discussed that also original concept was even they included left atrium as a part of the mitral valve apparatus.
Yes, sir. So mitral valve primarily includes mitral annulus, mitral leaflets, chorda tendineae, papillary muscles. All the four together they constitute mitral valve, out of which chorda tendineae and papillary muscles constitute subvalvular apparatus. When this mitral valve associate along with left ventricular valve and left atrium, all together constitute the mitral valve complex.
Okay, good. You put that again.
Yes, sir.
Now you can say which is the primary, which is secondary. That will be easy to understand.
Yes, sir.
In the table.
Yes, sir.
Tell.
So primary is particularly those pathologies which are involving primarily the mitral valve, mitral annulus, mitral leaflets, chorda tendineae, and papillary. All together they constitute the primary mitral regurgitation. When there is a functional deformity, either secondary to a left ventricular valve or left atrial abnormality, that leads to secondary mitral regurgitation.
Okay, so that point you have to remember.
Yes.
Okay.
Coming to the basic anatomy of the mitral valve annulus, mitral valve apparatus. Initially, the mitral valve annulus, annulus is nothing but it is a fibroelastic ring that encircles the valve orifice in a cone-like manner. And annulus is elliptical in shape in systole and circular in diastole. Mitral leaflets and commissures. There are two mitral leaflets, anterior mitral leaflet and posterior mitral leaflet. Anterior mitral leaflet is triangular in shape, is in continuity with the aortic annulus and answers on 1/3 of the annulus, but covers almost 2/3 of the valve orifice. Whereas the posterior mitral leaflet is quadrangular in shape and occupies around 2/3 of the annulus, but covers only 1/3 of the valve area. Next one is a Carpenter nomenclature to differentiate various parts of the anterior and posterior leaflet. This is anterolateral commissure and this is the posteromedial commissure, and they had divided into 3 scallops. Anterior is divided into 3 scallops and posterior leaflet is divided into 3 scallops. The anterior most is A1, in between the middle one is A2 and the posterior one is A3. In the similar way, the posterior leaflet is termed as the lateral third, that is anterior one is P1, the middle one is P2 and the posterior one is P3. The chorda tendineae, one minute. There are these are the fine fibrous strings radiating from the papillary muscles and attached to corresponding halves of the anterior and posterior mitral leaflets, and chorda arising from the anterior papillary muscle, primarily attached to the lateral half of the A2, A1 and anterior commissure, and P1 part of the posterior commissure, lateral half of the P2. whereas cord arising from the posterior papillary muscle attached to the medial half of the A2, A3 posterior commissure, P3 and medial half. Then nothing but the anterior anterior papillary muscle will be attaching more to the A1, P1 and A2, P2, a part of the A2 and P2, whereas posterior commissure will be more attached to the A3, A2 and P3 and P2. And papillary muscles, there are two papillary muscles and located at the junction
You
of...
put that,
Yes, sir.
no, that figure.
Yes, sir.
See, this you can easily remember this. This is all anterior, this is posterior. Like that. Otherwise, if you read that, you will have how to remember like that.
Yes.
So anterior is A1, A2 and P1 like that, and the posterior is more of a A3, part of A3 and like this.
Yes, sir.
Okay.
There are two papillary muscles, that is one is anterior papillary muscle and the posterior papillary muscle. Anterior papillary muscle is anterolateral, primarily connects to the anterolateral wall of the left ventricle, whereas the posterior papillary muscle connects to the posterior medial wall of the left ventricle. And the important thing to learn here is anterior papillary muscle has a dual blood supply, primarily from the obtuse margin of the circumflex artery and diagonal one of the left anterior descending artery, whereas the posterior papillary muscle has a single blood supply, primarily from the last obtuse marginal of circumflex or the right coronary artery. Coming to the...
That's why it is most commonly affected.
Yes, sir.
Dual supply, so one will compensate collaterals and other things, whereas papillary muscle rupture or dysfunction is more common with the posterior papillary muscle.
Yes.
Because of single blood supply.
Yes, sir. And mitral regurgitation. Carpenter classification is primarily used to define various types of mitral regurgitation. They had included both anatomical abnormality of the mitral wall, which leads to mitral regurgitation, that is primary mitral regurgitation, and also the functional abnormality of the mitral wall, which leads to functional regurgitation. So in these, primarily the type 1 as well as the type 3B are primarily considered as functional regurgitation, whereas in between type 2, type 3A and are considered as anatomical primary mitral regurgitation. So these are the various types of mitral regurgitation according to Carpenter classification, where the first one, in the first type, there will be normal leaflet motion. The second type, the type 2 will be having excessive leaflet motion both in systole and diastole, such as in mitral wall prolapse or papillary muscle or trauma. And the 3A is nothing but leaflet restriction. If it is both in systole and diastole, that is called as 3A. It can be seen in various conditions like rheumatic heart disease, SLE, radiation and drugs. And type 3B is in which there will be leaflet restriction, particularly in systole alone. This is the most common type of functional type of regurgitation. And this is the prime important type of regurgitation we review in the article below, in the next few slides. That is mostly the type 3B.
B.
Yes, sir. 3, but in that also type 3B, sir.
The same.
Yes, sir. And the article starts with a clinical vignette. I will be reading the clinical vignette. A 75-year-old man presents with dyspnea and fatigue, and that occurs with less than moderate physical activity. He had an ST elevation and myocardial infarction involving inferior and posterior segments of left ventricle 10 years ago, and since then the left ventricular ejection fraction has decreased from 40% to 25%, and accompanied with by increasing mitral regurgitation. And he was being implanted by an implantable left ventricular device around 6 months ago. His medications primarily include metoprolol, spironolactone, and torsemide. And how would you further evaluate this patient with the current clinical evidences that is being henceforth put forward by in this article? The clinical problem, that is the functional mitral regurgitation, initially had included some brief introduction, following that various modalities of investigation, and then the treatment, and finally what to do in these patients with that clinical vignette. That is the entire article. So first one is the clinical problem. The mitral regurgitation derives from anatomical or functional impairment of one or more components of mitral wall apparatus that are necessary for normal left ventricular function. It includes left ventricle, papillary muscles, chorda tendina, leaflets, and annulus. Any problem in any of these structures will lead to mitral regurgitation. And the two broad categories of mitral regurgitation are primary or the degenerative mitral regurgitation is most commonly caused by a leaflet prolapse or fail, or secondary mitral regurgitation, which is nothing but functional mitral regurgitation.
Actually, we used to call this functional mitral regurgitation when we were MBBS students like that. All this ischemic papillary muscle dysfunction, all those things. So that was taken away, and most of them, once this concept of mitral operators came, they said that better to identify anatomically and say that take out that functional like that. But still, some of the clinicians continue to use that. Now again, it has come back as functional is called now as secondary mitral regurgitation.
Yes. So primary mitral regurgitation is the disease of the wall or chordae, whereas secondary mitral regurgitation is the disease of the left ventricle or the left atrium in composite with the mitral wall. In a cross-sectional study involving persons older than 65 years of age, the prevalence of moderate to severe mitral regurgitation detected on transthoracic echocardiography was almost 2.3%. Just age itself is associated with 2.3% incidence of moderate to severe mitral regurgitation. And in another study, moderate to severe mitral regurgitation was identified in around 0.59% of a total of 30,000 adults roughly residing in Minnesota. The mitral regurgitation was classified as secondary in 65% of the cases, of which 60% were attributed to left ventricular remodeling or dysfunction, and the remainder were attributed to atrial function or flutter or to idiopathic annular dilatation. The severity of mitral regurgitation may vary dynamically as a function of left ventricular loading conditions, heart rhythm, conduction system disease, and myocardial ischemia. Ischemic mitral regurgitation is a type of secondary mitral regurgitation that.
So what are they as a function of the left ventricular loading condition and a preload?
Yes, sir.
So heart rhythm, conduction, and myocardial. Heart rhythm and conduction is mainly depend upon the rate like that, and myocardial ischemia.
Yes, sir.
Ischemia and rate.
Yes, sir. Ischemic mitral regurgitation is a type of secondary mitral regurgitation that occurs after myocardial infarction. Several studies have shown high risks of illness and death from cardiovascular disease among patients with symptomatic heart failure, reduced LV systolic function, and moderate or greater degrees of ischemic mitral regurgitation. It is also, and when compared to primary mitral regurgitation, secondary mitral regurgitation is associated with lower event-free survival than primary mitral regurgitation of similar magnitude, and adverse outcomes with severe secondary mitral regurgitation can occur in association with smaller regurgitant volumes than are observed in patients with remodeled primary mitral regurgitation. Whether secondary mitral regurgitation is simply a marker of poor outcomes due to left ventricular dysfunction, or whether it contributes independently to the long-term prognosis in these patients is uncertain till now. So this is a tabular form which he had tabulated and summarized all things. Mitral regurgitation is broadly classified into two. Mitral regurgitation is broadly classified into two categories, that is primary and secondary mitral regurgitation. And the evaluation, treatment, and prognosis in patients in these conditions differ. Primary mitral regurgitation is usually caused by leaflet abnormalities such as prolapse, whereas secondary mitral regurgitation results from abnormal left ventricular size, shape, or function. And transthoracic echo is the most frequently used test to determine the cause, mechanism, and severity of mitral regurgitation. And guideline-directed medical therapy is the first-line approach in the treatment of patients who have heart failure with secondary mitral regurgitation and reduced left ventricular function. Surgical or transcatheter intervention should be undertaken only after the patient has received a maximum dose of mitral therapy without adverse effects. And surgical treatment of secondary mitral regurgitation consists of downsized annuloplasty repair or replacement, and surgery has not shown to improve the long-term survival among these patients. In one of the two randomized trials of transcatheter edge-to-edge repair involving patients with secondary mitral regurgitation and reduced LV ejection fraction, Guideline-directed medical therapy plus TER significantly decrease the incidence of hospitalization for heart failure or death from any cause at 2 years. The concept of differentiating mitral regurgitation as a proportionate or disproportionate has been proposed to explain the benefit of transcatheter edge-to-edge repair for secondary mitral regurgitation, and prospective validation of this concept is needed henceforth to be studied.
This is the final summary.
Yes, sir. Initial part, sir. Again, he had summarized it.
Yeah, no, he has covered everything, including management, also in this table.
Yes. And various strategies and evidences. The clinical recognition of secondary mitral regurgitation begins with detection and characterization of systolic heart murmur that is considered within the context of patient's history, symptoms at presentation, and other evidences of underlying cardiac condition. Example, abnormalities of ECG or chest radiograph. Although the murmur can be difficult to detect, bedside maneuvers to increase left ventricular outflow may increase its intensity. The identification of the cause, mechanism, severity, and consequences of mitral regurgitation relies primarily on the performance of transthoracic echocardiography and assessment of the morphological characteristics like motion of the mitral wall leaflets, size and calcification of the annulus, left ventricular and left atrial volumes, global and regional left ventricular systolic function, pulmonary vein flow, pulmonary arterial pressures, right ventricular function, and the presence of tricuspid regurgitation. The nature of secondary mitral regurgitation is dynamic, so the patient's blood pressure and heart rate and rhythm should be recorded, and TT transthoracic echocardiography often reveals more mitral regurgitation than can be detected on physical examination. This is a diagram which he had posted in the article. The left-sided showed an enlarged apical 4-chamber view without a color Doppler. On the left side, the posterior mitral leaflet is tethered, and there is a tenting of both the leaflets above the wall plane during systole. The left ventricle and the left atrium are enlarged. On the right side, there is an eccentric jet of mitral regurgitation directed posteriorly and laterally into the enlarged LA with an area of accelerated flow convergence at its cap. The mitral regurgitation was severe according to the multiple criteria. Coming to the classification and assessment, the Carpenter classification, which categorizes mitral regurgitation on the basis of normal, excessive, or restricted leaflet mobility, can be useful for clinical categorization and surgical planning. In this article, the Carpenter type 3B, which is the main focus in this article for mitral regurgitation, is attributed to restricted mitral wall leaflet motion during systole in patients with an ischemic or non-ischemic cardiomyopathy. In patients with ischemic mitral regurgitation, mitral wall leaflets are also thickened and fibrotic with reduced lengthening. It occurs mitral regurgitation most often occurs as a consequence of adverse left ventricular remodeling with papillary muscle displacement, leaflet tethering, reduced mitral wall closing forces, annular dilatation, and failure of leaflet coaptation. And in some patients with ischemic mitral
that sentence gives all that pathophysiology.
Yes.
Adverse ventricular remodeling, papillary muscle displacement, tethering, reduced mitral wall closing forces, annular dilatation, and leaflet coaptation. See, as that's 6 or 7 points, or each one is 1 point like that.
Yes.
Okay.
In some patients with ischemic mitral regurgitation, however, left ventricular is not substantially remodeled, and with atrial functional mitral regurgitation, mitral wall, that is Carpenter type 1, where it is also a type of functional mitral regurgitation, but with atrial functional mitral regurgitation. That is nothing but abnormality of the left atrium, where the mitral wall leaflet motion is normal, and the mitral regurgitation is due to the left atrium and annular enlargement with insufficient leaflet lengthening, as occurs in some patients with chronic persistent atrial fibrillation with enlarged left atrium.
Actually, the posterior leaflet is very closely attached to the left atrium, little inside like that. So that's why whenever the left atrium enlarges, the posterior leaflet is dragged in. So that's why there is a coaptation is gone and mitral regurgitation occurs. So that's why that fellow gave the terminology as MR begets MR like that. That means that's mainly applied for the left ventricle, but subsequently it was applied for other things also, LV dilatation, all those things. So mainly the posterior leaflet is the one which is the culprit in this left atrial enlargement and which causes mitral regurgitation. Even that Liebman sacs also, most commonly it involves the posterior leaflet rather than anterior leaflet in SLI, because that will cause fibrosis and drags into the left atrial wall, and you will get MR like that. Okay.
The severity of mitral regurgitation should be measured objectively. However, quantitative assessment of severe secondary mitral regurgitation is difficult because of geometric assumptions and technical challenges. In patients with ischemic mitral regurgitation, measurement may be inaccurate because of the eccentric nature of the jet and crescentic shape of the regurgitant orifice.
Okay.
There is a difference between American College of Cardiology and European Society of European Society of Cardiology regarding the definition of secondary mitral regurgitation. According to American College of Cardiology, they define secondary mitral regurgitation on the basis of effective regurgitant orifice area of at least 0.4 centimeter square and a regurgitant volume of 60 ml or more. Whereas the European Society of Cardiology and have taken a lower cutoff points with effective regurgitant orifice greater than 0.2 centimeter square and regurgitant volume greater than 30 ml for severe, because maybe European Society had thought that even a small orifice area of 0.2 centimeter square for with regurgitant volume itself is sufficient to consider a case of mitral regurgitation as severe if it is secondary. These cutoffs are based on the data on natural history of this condition that link these to lower values.
Regurgitant volume 30 or less than that is mild, and 30 to 60 is moderate, more than 60 is severe. So that's why. So this you have to remember. This actually many times I have a discussion with Manjunath and all those things. I say that no, you cannot have both mitral stone severe and severe MR like that. Then he says, Sampath, the effective orifice area is 0.4 or 0.5 centimeters, so which is a very tight obstruction. Then even regurgitation can occur like that. No, that is true by theoretically, but in a clinical situation, it doesn't occur.
The American Society.
Remember, even the effective orifice area for the aortic wall also. Okay?
Yes, sir. The American Society of Echocardiography guideline caution that secondary mitral regurgitation may be severe even with an effective regurgitant orifice area of 0.3 centimeters or more because of limitations in the technique used to measure it. One echocardiographic finding in isolation cannot define the severity of MR, and thus an integrative approach is needed.
That point finally you have to remember, that is integrative approach means you have to take everything into consideration. Symptoms, history, electrocardiogram, LV function, everything, and finally decide.
When assessment of anatomy and function of mitral valve by means of transthoracic echocardiography is not adequate, transesophageal echocardiography and cardiac MRI can provide more specific anatomical and hemodynamic detail. Because the patient has been sedated during a transesophageal echocardiography, the performance of this test can result in favorably altered left ventricular loading conditions and reduce severity of secondary mitral regurgitation. And these observations made on transthoracic echocardiography while the patient is awake should be used in clinical decision making.
We don't sedate the patient, no?
Yes. Cardiac MRI can provide accurate measurement of left ventricular volumes and detect areas of myocardial scarring and assess for regional ischemia. And exercise transthoracic echocardiography may be useful when there are discrepancies between the clinical findings and data from the non-invasive testing. And cardiac catheterization with hemodynamic assessment, coronary angiography, and left ventriculography has a role in selected patients, particularly those with known or suspected coronary artery disease. And regarding the medical therapy or devices, there is a lot of confusion regarding the treatment of secondary mitral regurgitation. And because various trials have shown non-improvement of secondary mitral regurgitation despite devices or surgeries. So, going in detail regarding the medical, surgical, and transcatheter therapies, henceforth. First is medical therapy. Regarding the recommendations regarding the treatment of secondary mitral regurgitation are based on multiple variables, including the type of secondary mitral regurgitation, severity of secondary mitral regurgitation, hemodynamic consequences of secondary mitral regurgitation, coexisting conditions, and the experience and expertise of multidisciplinary team providing care. And guideline-directed medical therapy is the first-line approach in patients who have heart failure with reduced left ventricular ejection fraction and secondary mitral regurgitation. And it is provided preferably with the supervision of the heart failure specialist. Randomized trials involving patients who have heart failure with a reduced ejection fraction, some of whom had secondary mitral regurgitation, have shown functional and survival benefits of beta blockers, inhibitors of renin-angiotensin aldosterone system, angiotensin receptor neprilysin inhibitors, and sodium glucose co-transporter 2 inhibitors. And step therapy with these agents and others is implanted over a period of weeks to months. Both carvedilol and sacubitril valsartan have been shown to reduce the degree of secondary mitral regurgitation. Cardiac resynchronization therapy can improve left ventricular function with decreases left ventricular size and reduces the magnitude of mitral regurgitation in selected patients who have heart failure with reduced ejection fraction and left ventricular branch, particularly those patients with QRS duration more than 150 milliseconds. And in patients with atrial functional mitral regurgitation, such as in patients with atrial fibrillation, restoration and maintenance of sinus rhythm can reduce the left atrial size, mitral annular dimensions, and degree of mitral regurgitation. And attention to the principles of secondary prevention of coronary artery disease, including lipid management, reduction in risk of sudden cardiac with use of ICD or stroke, is important. In contrast to, regarding the next one is surgery. In contrast to primary mitral regurgitation, for which
you talk intervention, then surgery.
Oh, okay, sir. Then I'll. The recent most important thing is.
Okay, otherwise surgery you do it afterwards.
Yes, sir. Because in this article, maybe he thought surgery is well known, so first he included surgery, sir. Then he had mentioned about catheter therapy. Okay. In the contrast to primary mitral regurgitation, for which valve surgery is
also indicated. Surgery is a risky thing, high risk patients.
Yes, sir.
So surgery is tough, complicated, and risk is high.
Yes, sir. For in contrast to primary mitral regurgitation, for which valve repair is indicated when symptoms develop or when certain thresholds for left ventricular size, function, or both are met. This is very important in case of functional. Surgical or transcatheter intervention for secondary mitral regurgitation should be pursued only in patients with persistent symptoms and residual moderately severe or severe mitral regurgitation despite an adequate 3 months trial of guideline-directed medical therapy. And surgery for secondary mitral regurgitation consists chiefly of either repair with a downsized annuloplasty ring or valve replacement with caudal sparing. And in patients with ischemic mitral regurgitation, coronary undergoing CABG, valve replacement may be considered. Surgical ablation for atrial fibrillation, amputations of left atrial appendage, or other valve surgery is undertaken or indicated. And although many case series showed improvement in left ventricular function and shape in patients with dilated cardiomyopathy and secondary mitral regurgitation with insertion of a downsized annuloplasty ring, a subsequent propensity matched cohort study from the same institution showed that survival was not longer among patients who underwent repair than among those who received medical therapy alone. Data from randomized trials comparing mitral surgery with medical therapy or transcatheter therapy in patients with ischemic mitral regurgitation are lacking. So
all the three head-to-head comparison is not available.
Yes, sir.
Like medical therapy, transcatheter, and surgery.
Yes, sir. So in the randomized trial comparing mitral valve repair with caudal sparing, mitral valve replacement in 251 patients with severe ischemic mitral regurgitation, Those assigned to mitral valve replacement had a lower incidence of moderate to severe mitral regurgitation after surgery, fewer side effects related to heart failure, and a fewer readmissions for cardiovascular causes at 3 years. But the most important thing is there is no significant difference in survival at 2 years despite surgery. Thus, in contrast to severe primary mitral regurgitation for which valve repair is preferred over replacement, valve replacement may be preferred for treatment of severe ischemic mitral regurgitation. And in another randomized trial involving patients with moderate ischemic mitral regurgitation, there was no difference between mitral valve repair plus CABG and CABG alone with respect to the magnitude of left ventricular reverse remodeling. And survival was not longer with mitral valve repair plus CABG than CABG alone. So currently there is no evidence to say that surgery with associated CABG may have improved outcome when compared to surgery alone.
That trial we participated also. We contributed some 7 patients who same thing, severe triple vessel disease patient who required surgery and associated LV dysfunction with MR, whether they will benefit from surgery or not. And it did not show much benefit. Medical therapy and these things almost, survival rates were same, but surgery patient had a little better lifestyle. They had less symptoms.
Next one is transcatheter repair or replacement. Transcatheter intervention for mitral regurgitation, as shown in the left side, that is a normal heart. Mitral valve is competent and systolic flow is directed out of the aorta. As shown in B, the left ventricular remodels after myocardial infarction with displacement of papillary muscles and restricted movement of the posterior mitral valve leaflet, resulting in mitral regurgitation. And transcatheter intervention for mitral regurgitation. A catheter. This diagram is primarily showing the procedure. A catheter will be passed. A catheter containing mitral valve clip device is threaded into the inferior vena cava into the right atrium, across the intra-atrial septum into the left atrium, and across the mitral valve leaflets. This procedure is performed from transesophageal and fluoroscopy guidance. And following that, the device is positioned to grasp the mitral valve leaflets and clip them together in the region of the jet of mitral regurgitation. This is how it is clipped. And following the clipping, as shown in figure F2, F, G, and H, edge-to-edge clipping results in decrease in the magnitude of mitral regurgitation, and placement of clip results in the creation of a double orifice of mitral valve. And this, the view in H from this is a double orifice mitral valve. Looking into in this example, the clip has been placed across the mitral scallops of the anterior and posterior leaflets, creating a ridge of tissue that separates the two.
Actually, I think that fellow's name I'm forgetting. Yes, it will start with. He's a Russian surgeon who did the mitral regurgitation and the double orifice technique like that. So he took out both the leaflets and stitched them together so that the size comes down and like that. So that concept was taken by the interventional cardiologist, and we do same thing, clipping. Say you pass that catheter and that will have a stitch-like thing, and then you put a stitch so that the orifice size comes down and you'll have double orifice like that. Yes, what is that name? Forgot, Raju?
Alfiris technique, sir. I don't know.
Same thing.
Alfiris.
That fellow, he's a Russian surgeon actually.
Yes, sir.
So he was doing surgical technique, but so that concept was taken by the interventional cardiologist. So surgery is a major thing. You have to go for pump, all those things. So this is without all those things, you can put that. So that is now coming there.
Yes, okay. Sir. The transcatheter intervention for mitral regurgitation. In transcatheter intervention for my MR, the use of mitral clip which was being produced by Abbott vascular to create an edge-to-edge approximation of the mid-portion of mitral valve leaflets results in a double orifice mitral valve. The favorable outcomes in both randomized and observational studies resulted in the 2013 FDA approval of the clip for the treatment of patients with mitral primary mitral regurgitation who are at high risk for surgery-related complications or death. So in the year 2013, FDA had approved MitraClip for the treatment of ischemic secondary mitral regurgitation. Following that, the patients around in most of the places, around 300 centers in USA have started using it. And following that, around 5 to 6 years, there had been two important trials that had come out on transcatheter therapy. That is, the first one is COAP trial and the second one is MITRA-F trial. So first one had shown very good results, but the second one failed to show good results, which led to a lot of confusion in all the cardiology community whether to use it or not use it. So this confusion is cleared by this article. And subsequently, the cardiovascular outcome assessment of MitraClip prevention percutaneous therapy for heart failure patients with functional mitral regurgitation randomly assigned 614 patients with secondary mitral regurgitation, approximately 60% of whom had ischemic cardiomyopathy and symptomatic heart failure, with a reduced LV ejection fraction to either transcatheter edge-to-edge repair plus guideline-directed medical therapy or medical therapy alone. The addition of TER, that is edge-to-edge repair, to medical therapy resulted in significantly fewer hospitalizations for heart failure and improved survival at 2 years with a low incidence of device-related complications. So this is a landmark trial which showed a very good outcome for MitraClip. But subsequently, a second randomized trial that used the same device, the percutaneous repair with MitraClip device for severe functional by secondary mitral regurgitation, which involved 304 patients, that is MITRA-FR trial, showed that the 1 year and 2 year follow-up results of the trial showed no significant differences between patients who received guideline-directed medical therapy plus TER and those who received guideline-directed medical therapy alone, with respect to the composite outcome of death from any cause or unplanned hospitalization for heart failure. So the major difference between COAPT and MITRA-AF trial may be due to various possible reasons which are being proposed for these discordant results include difference between the trial sample size, that is the COAPT had included 600 whereas MITRA-AF included only 300. The difference in the severity of baseline mitral regurgitation, baseline left ventricular size, rigor of medical therapy, degree and durability of the reduction in mitral regurgitation, and the operator experience. Because maybe in MITRA, once it is recognized, the number of operators might have improved. So it's leading to a change in the operator experience who are using them. So another proposed explanation is that the benefits of TER in patients with secondary mitral regurgitation may depend on the relationship between the left ventricular size and the severity of the mitral regurgitation. So the benefits are greater when the degree of mitral regurgitation exceeds or is disproportionate to that which would be expected for the size of the ventricle alone. So such disproportionate mitral regurgitation was more common in patients in the COAP trial who had more mitral regurgitation and small ventricles than patients in MITRA-FR trials. Although a COAP sub-study of echocardiography findings showed consistent benefits of TER across numerous baseline echocardiographic measures, a post-hoc analysis involving small group of patients in the COAP trial who more closely resembled patients in the MITRA-FR trial and who had mitral regurgitation that was considered to be proportional to the degree of LV dilatation did not show any benefit with the TER. So, patient selection for TER is an evidence process and must involve consideration of numerous clinical, imaging, and hemodynamic variables. In patients with secondary mitral regurgitation, important transesophageal echocardiography findings to predict feasibility of TER include leaflet coaptation depth, coaptation length, grasping zone between leaflets, and the presence, extent, and distribution of calcification of the mitral wall. The FDA approved the MitraClip device in March 2019 for use in patients with secondary mitral regurgitation who met the inclusion criteria of the COAP trial. And when I have searched in the Google, there is one more important study that is actually a review article that is being published in European Heart Journal. So that is MITRA-FR versus the COAP, lessons from the two trials with diametrically opposed results. They had tried to analyze what happened, what is the difference between the two trials, and based on this study of these two trials, they had published one more article in European Heart Journal. So they had involving all the patients from MITRA-AFR and COAP trial, altogether they have segregated the patients into 4 categories based on the severity of LV dysfunction and the severity of MR. And altogether these 900 patients kept together, they found out that patients with mild to moderate LV systolic dysfunction with LV ejection, the mitral clip is best useful in this area, where in patients with mild to moderate LV systolic dysfunction with minimum of LV ejection fraction equal to or more than 20, with LV end systolic dimension of less than 70, with moderate to severe MR with effective orifice area greater than 30 mm and regurgitant volume greater than 40 mm. Whereas in the rest of the population, either it is futile or the result was uncertain. So based on this, in the European Society of Cardiology in the year 2019, they had published, and finally they had come to a conclusion that I'll be reading the entire conclusion of this article. Mitra FR and COAP targeted the same disease entity with the same device, the Mitra clip. However, COAP enrolled a subset of patients who had more severe MR, less advanced LV disease, that is dilatation or dysfunction, compared to Mitra FR patients. These differences may explain the different outcome observed in COAP versus Mitra AFR. Indeed, patients with too severe LV dilatation by LV dysfunction may not benefit from the Mitra clip procedure. In light of the results of Mitra FR or COAP trials, it thus appears reasonable to conclude that Mitra clip procedure reduces heart failure, hospitalization, and mortality in patients meeting the following criteria. The criteria: moderate to severe secondary mitral regurgitation, defined with an effective regurgitant orifice area greater than 0.3 mm square or regurgitant volume greater than 45, and ejection fraction between 20 to 50% with LV and systolic diameter greater than less than 70, with persistent heart failure symptoms despite optimal guideline-directed medical therapy with cardiac synchronization and coronary revascularization when it is appropriate.
So this patient, you remember, you put that again.
Yes, sir.
So they said valve area of less than 0.3, and then EF, which is not very severe, like that, between 20 and 50, moderate LV dysfunction, less than 70 end systolic diameter, not end diastolic. That means very big heart. And heart failure symptoms of class 2 more than even with the treatment.
Yes, sir. So these criteria, what this article had included, the criteria are symptomatic heart failure with ejection fraction of 20 to 50% and moderate to severe or severe mitral regurgitation despite guideline-directed medical therapy, plus cardiac resynchronization therapy if indicated, with a left ventricular end systolic dimension of less than 7 centimeters and a pulmonary artery systolic pressure of less than 70 mm Hg. Other transcatheter approaches to repair secondary mitral regurgitation includes devices that target the mitral wall leaflets or reduce the size of dilated annulus. So devices for mitral wall replacements are also under investigations. Early studies have focused on feasibility, device performance, safety, short-term efficacy in patients with a high or prohibitive risk of surgery-related complications or death. So guidelines, international practice guidelines for the care of patients with valvular heart disease were most recently updated in 2011 before the publication of the results of COAP and Mitra FR trials in 2018. And these guidelines were conservative in the recommendations regarding surgery for secondary mitral regurgitation. Now, mitral valve surgery was recommended or considered to be reasonable for patients with severe secondary mitral regurgitation who are undergoing CABG, and the guidelines noted that isolated mitral valve surgery could be considered for severe secondary mitral regurgitation in selected patients with severe symptoms despite the use of maximum doses of guideline-directed medical therapy without adverse effects. So the surgical approach was not rigorously specified, although ACC AHE guidelines stated that it is reasonably to choose replacement in preference to repair with a downsized annuloplasty ring for patients with severe ischemic mitral regurgitation. The 2017 guidelines for the European Society of Cardiology also suggested a possible role of TER in the treatment of severe secondary mitral regurgitation in patients who have heart failure with reduced ejection fraction and persistent treatments with use of maximum doses of guideline-directed medical therapy without adverse effects. The present article differs from the current guidelines by taking into account the results of both coapt and mitral effort trials. So these are the various guidelines that have been put forth by ACC in 2017. That is a class 2A recommendation for
Okay.
mitral.
I think okay.
Yes, sir.
Same thing.
The areas of uncertainty, the disparate results of coapt and mitral effort trials have confused the clinical community. A third trial, a clinical evaluation of the safety and effectiveness of mitral clip in the treatment of clinically significant mitral regurgitation of the same device in some similar patients is currently recruiting patients and is designed to provide additional data to guide the appropriate use of edge-to-edge repair in patients with secondary mitral regurgitation. Currently, more than 380 US centers offer edge-to-edge repair for mitral regurgitation. Whether they can produce the rigor applied in the coapt trial to achieve similar results in a real-world setting is uncertain. So, regulatory criteria for upload of new transcatheter repair and replacement devices need to be developed, and prospective validation of the concept of differentiating secondary mitral regurgitation as proportionate or disproportionate to guide patient selection for mitral intervention is needed. Despite clear recommendations for guideline-directed medical therapy, treatment is often not sufficient, and mortality among patients who have left ventricular with reduced ejection fraction and secondary mitral regurgitation remains very high. And given the results of coapt trial, the role of surgery
No, that tell 29% at 2 years.
in the device group of the coapt trial, and effective strategies are needed to improve guideline adherence. And given the results of coapt trial, the role of surgery in the management of secondary mitral regurgitation has become less clear for patients in whom there is no other primary indications for operation, such as coronary artery disease, for which CABG would be preferred or PCI. So finally, in this patient, which was being presented in the clinical vignette for whom the ejection fraction was slowly coming down with the increasing severity of mitral regurgitation, the cause, mechanism, and severity of mitral regurgitation should be evaluated by means of transesophageal echocardiography, and an assessment of myocardial ischemia and viability should be performed. The first line approach should be to initiate a regimen for heart failure that includes a low dose of angiotensin and converting enzyme inhibitor adjusted with attention to the patient's blood pressure, renal function, and potassium levels, followed by an attempt to switch to an angiotensin receptor neprilysin inhibitor. And efforts should be made to administer the doses of medication that have been shown to be useful in randomized heart failure trials. Cardiac resynchronization therapy should be considered if indicated. If severe heart failure symptoms persist after the use of maximum dose of guideline-directed medical therapy without adverse effects for 3 months, edge-to-edge repair may be considered if the patient meets the inclusion criteria of the coapt trial noted above, and the transesophageal echocardiography assessment of the leaf structure and motion indicate that this is feasible in this patient. They would consult with a multidisciplinary team that concludes a heart failure specialist, echocardiographer, interventionalist, and a surgeon to seek a conscientious recommendation regarding the best treatment strategy, and they would pursue a shared decision-making process with the patient and his family.
Okay. I think it has comprehensively covered everything.
Yes, sir.
You observed most of the time when they talk the topic, finally they end with two important trials which are given the concept or where the concept has not been proved like that. You take any review article.
Yes, sir.
They quote the two important trials, recent early trials, and then finally, see now they have quoted mainly coapt and FFR trial, that trial.
Yes.
Huh?
Yes, sir. Mitral effort trial.
Okay, good. I think all of you be thorough with that because it can be asked either interventional techniques for mitral regurgitation or secondary mitral regurgitation, or even in the clinics. I think we may don't go into the details, but we may ask what is the mitral clip procedure, what is the philosophy means you have to say that to reduce the annular size and you make a double orifice such a way that the mitral regurgitation comes down. That is it. One more technique is there is not used. Another thing was to reduce the annular size. You put a stent like spring-like structure in the coronary sinus. See, coronary sinus is a posterior structure and it goes in the AV groove, left AV groove. So that's why, so through right atrium, you go there and you put a self-expanding stent so that when the coronary sinus compresses, the annulus comes down. See, when it is expanding, what happens? Annulus will come down the size.
Yes, sir.
The annulus will not have space to go out externally. So that was tried, but that came nearly 15-20 years back, but it did not get much attention. So these were the two interventional techniques which was I forgot his name. I used to
Alfiri. Alfiri.
Alferi.
Alfiri, sir.
FERI, I think.
ALFERI.
That's Alferi. Alferi stitch.
Yes, sir.
Okay. What about the hospital? As usual.
They had started IP, sir.
Huh?
They are trying to start IP, sir, but none of the patients are getting admitted, it seems.
Okay.
Slowly, I think they will start by this month and, sir, it will improve.
Okay. Probably in November only I may be able to come. Huh?
Yes, sir. Maybe by November, sir. I think maybe in one more month, I think it will take time, sir.
No, this month they paid salary full. Then probably they expect us to come. I think. What about this our selection?
Not yet updated, sir.
No, but that will be decided or not decided?
Don't know, sir. It's still in the court. They are waiting for the court orders.
So any prospective candidates for our department?
Not yet, sir. Only one person consulted, sir.
Huh?
Only one person has consulted.
Now, what happened to our students that Sham and that Ramya, they were interested in cardiology like that?
Don't know.
Ramya didn't write the exam, sir.
Huh?
Ramya didn't appear for the exam, sir.
Oh, she did not appear.
Yes, because
Why?
because of her relatives had COVID, sir, something like that.
That relative COVID, why is she?
And her father-in-law or mother-in-law, sir.
Oh, I see. Okay. That fellow Sham,
Sham, he got around 400 ranks, sir.
who?
Sham, sir.
So he will be joining, huh?
He's not yet decided, sir.
You ask him to join.
Okay.
Mastan,
Sir,
that fellow, NEET, he got 720, all correct.
yes, sir. Out of 700.
I thought he is your brother, I think. Just like you. I thought probably, I wanted to ask, but when I read it, he is from Orissa.
Orissa.
Huh?
Yes, sir. He is from Orissa, sir.
Then I thought he may not be related to our Mastan, I thought. Do you see the photograph?
Yes, sir. In today's paper, I have seen, sir.
So the similarities are there, na? No, really, you see, Ashok, Sandeep,
Yes,
you see that photograph of that fellow Aftab.
Okay, sir.
You will think that he is brother of Mastan. No, you really, when I saw, I thought, but when I read it, they said he is from Orissa. Probably it is not corrected. If you are from Hyderabad or Vijayawada, definitely. You have seen the photograph, Mastan?
Yes, sir. I have seen, sir.
That fellow got all 180 questions correct.
720 out of 720, sir.
No, other girl also got it,
Yes, sir. Yes,
but
sir.
they took the other criteria like subjects or age like that, and they gave them first rank to this
First rank.
person and second rank. And our one more thing is our Sadanand Reddy is their cardiologist in our Medicity.
Sir.
When he was a student, he was our student, and I was. When he appeared for the exam, I was the registrar also. So his daughter got third rank.
Oh.
Snitika.
Tummala Snitika.
Snitika.
Okay.
So actually, that some last month he was telling, sir, my daughter is a second year intermediate. She studies well, he said. Then okay, she's neat. She wants to become a doctor and neat, and then she will join in Usmania. You can straight away she will get it. I said, no, sir, she is aiming for AIMS. Then better, I said, if she gets AIMS, that's better. Otherwise, you can join her in Usman, I said. But now she got third rank, and I think she's joining in AIMS only.
AIMS is a separate exam, I think.
Yes, sir. Separate exam.
No, take it out.
This time.
Now this year, all are the same. No, the JIPMAR, everything are all together. There's no separate.
Okay. Most of the toppers in their interview they are telling they want to become cardiologists, sir.
Yeah, neurosurgeon bole two people.
Yes, sir. One female, she answered as neurosurgeon, but most of the people they are telling that they want to become cardiologist and need to serve poor people like that.
And that is usual. Actually, Sadanand Reddy did not come today to the hospital. Otherwise, I wanted to talk personally. But I rang up and told him congratulations. I would like to tell him, I think don't put her like you into the practice. You let her be in an academic institution, medical college like that, so that, see, that talent should be useful now.
Yes, sir.
See, if you are in an academic institution, you can impart knowledge to many people and make them big, good doctors. If you're in practice, you're helping only one patient or one family. You understand? And in even if you're in a medical college, you can do all the work and help also. That part. Only money is the one which makes the difference. I think this time, I think both seats may be filled up, I think.
Yes, sir, it will be filled up.
Huh?
Yes, sir.
Fees is over, huh? That Jiva has come?
No, sir,
Fee
not yet come, sir. No, sir,
fee
not
structure.
Not yet come, sir.
Why?
No idea, sir.
Jagan is busy with that letters, all those things.
Just it, sir. You but just it, sir.
Somebody sent yesterday one Raghuram Krishnaraju's YouTube clipping.
Yes, sir.
In that he said, he says sorry and withdraws the statement, otherwise he will go to the behind bar as a
Contempt of court.
contempt of court, and he will be. No, I think too much that is wrong. He cannot write. No, he can see governor. He can write a letter to the Chief Justice, but he cannot make a press meet and release to the public. You understand?
Yes.
And I don't know. BJP is not talking. What is their idea? We don't know.
Yes, sir.
JP people need YCP support, sir, in Rajya Sabha and.
So that's why they are not worried that whether criticize or not. Okay.
Yes.
And all the advocates association bars, they are writing a letter CGI. You should take it seriously and don't leave it like that. Once they start they take again, call him and take the opinion, everything, and if he says, they will exempt. Otherwise, they'll take punishment. And that fellow was telling the punishment, Prashant Bhushan, they put one rupee, na? Shanti.
Yes, sir.
So Even 1 rupee punishment also you're a criminal. So then you'll be ineligible to become a CM. You have to resign, all those things. That Krishnam Raju was talking. Ram Krishnam Raju. Yesterday I heard some 15, 20 minutes. Very interesting. He's sarcastic, like he says that he's our beloved chief minister, our party president, but criticizing.
Now he is out of the party, sir.
Not yet expelled. No, no, they are not expelled.
Oh,
They have given a show cause notice, he has given the reply, but there's no action taken. No, if they expel, then he will not lose the MP sheet. You understand? If he joins some other party, then he will be disqualification can occur.
okay, sir.
So that's why they don't. He will not resign. He'll go on talking like that, and they should get fed up and say that, okay, you're expelled from the party. Then he is free to join wherever he wants,
Okay, sir.
and his MPship will continue.
Okay, okay.
Okay, next Wednesday, what are we talking?
I will talk on aortic dissection, sir.
Okay, I think that also, I think some article came, I sent it, I think.
Yes, check it, sir.
Huh? No, I think I sent that aortic dissection, recent concept. One thing they divided is before subclavian and post subclavian. Management the same.
Yes.
See, before subclavian, then the arch, everything will be involved. So there's a different strategy when compared with post subclavian is. No, I think that article I sent to the Stanford people. They have studied this 40, 50 years of dissection and what the management, and they gave finally the concept of what to do like that. I think I sent that article journal I published and I sent it. So that in that they have written, and final essence was whether it is before subclavian or post subclavian. Post subclavian people, there's not much danger, there's not much of a mortality or like that, and pre-subclavian, that means involving the arts like the stroke, all those things are there, and cardiac dysfunction, all those things. So they people, so that was the final essence they gave that concept. I think you see that the
Okay.
Stanford people recently published that article. I think in JACC only or JACC only or any jam, I don't know. I sent that also.
I'll just check it.
In that they have written same thing. And then I read it, and final essence I knew that dissection before subclavian you have to do emergency something. Post subclavian you can wait, evaluate, and then take decision. You write it, Stanford dissection recent guidelines. A recent study. That was a meta-analysis of all the patients which they have operated or treated, and finally they gave that final essence. And for me, I need not go numbers, all those. The final thing we want to know what to do for the patient. Okay.
Okay.
Dissection, the 2-3 DeBakey classification is there, and Stanford.
Stanford.
Now most commonly used the Stanford only, and that you check for that article, Sandeep.
Okay, sir. Okay.
There are 50 years of all their surgeries which have done, they reviewed and finally gave this concept. Pre-subclavian is emergency, you have to do something. Now interventions or surgery. Post-subclavian, you can wait, evaluate, and then take decision. Okay.
Okay.
Thank you.
you.